Bipolar depression. Nicol.
Hey, thank you very much. Thank you very much for coming back. So yes, as Hamish mentioned, this bipolar depression, unfortunately, despite it's a very common disorder, we actually have a very poor selection of evidence on which to decide our treatment. So I'll try and take you through it and then together and bring it together at the end in some kind of conclusion. So what I'm going to talk about, a brief introduction to the clinical features of bipolar depression and something about their associations. Then I'm going to look at, the way I'm going to do it is to divide the management of bipolar depression up by looking at different classes of drugs, antidepressants, mood stabilizers, antipsychotics, and then a little bit on physical treatments, and then try and bring it all together at the end. So in terms of an introduction, the first issue I want to raise is the question of where to get good information on this topic. And as Hamish mentioned, the NICE, that's the National Institute for Clinical Excellence in the UK, I think internationally recognised as a very good body for reviewing data and producing guidelines. Now, they're quite strict guidelines, so if anything appears in NICE, it's usually then associated with really quite good evidence and strong evidence, and they set quite a high threshold. So the NICE guideline for bipolar disorder has just been published in 2014. It's called Clinical Guideline 185, and it is freely available on the internet, on the web. And Hamish mentioned it has a few problems, but I think as far as bipolar depression is concerned, it's actually quite good. And so I'd recommend that as a source of good data. Hamish also mentioned the BAP guidelines published in 2009, and I think these are excellent clinical guidelines, more user-friendly than the NICE guidelines. And they're also available at the BAP website, freely available. And a new version will be appearing, hopefully, at the latter end of this year. And finally, there's the World Federation of the Society of Biological Psychiatry guidelines, published by Heinz Grunz and others, which is a very comprehensive review of all the data on the topic, at least up till 2010, which can also be recommended for treatments that don't perhaps have a lot of evidence, but some evidence. So what about depression and bipolar disorder? Well, as we know, most of the episodes are depression. It's usually the first episode. Some patients do present with mania for the very first time out of the blue, but most patients present with depression in their first episode, usually in adolescence. And we know that if you present with depression as your first episode, then your outcome in the longer term is poorer than if you present with mania as your first episode. Now, a lot of patients, despite all our improvements in treatment with bipolar disorder, still do badly. They still have a poor outcome psychosocially in terms of return to work and that sort of thing, and return to pre-morbid function. And that is associated, that poor outcome, social outcome, is associated with the amount of depression and the frequency of depression a particular patient has. It's associated with quite prolonged destabilization of mood. So while mania is a very serious disorder, it gets well quite quickly, whereas depression takes a long time. It's associated with the increased suicide risk, and again, despite our improved treatments in bipolar disorder, the suicide rate remains high. This is probably due to a combination of impulsivity, which many bipolar patients have, and their depression. But depression is clearly a big factor in why the suicide rate, and of course the risk of suicide attempts is also high. It's associated with an increased prevalence of abuse of substances such as illicit drugs and alcohol, and with anxiety, and also with the increased mortality rate that we see in bipolar disorder. Bipolar patients on average live 10 years less than other members of the population. Some of that's due to suicide, but some is also due to cardiovascular deaths or other deaths. And that can be seen to be associated with the amount of depression the patient has. And interestingly, patients on treatment have a better mortality, a longer lifespan than people who don't take treatment. Now, people often ask, is the depression in bipolar disorder the same as it is in unipolar depression? And largely it is, but there is some interesting differences. And one of those may be that in bipolar depression you get greater retardation, greater slowing up. and that may be a clinical difference, and it also might link to the fact that the drug treatments for bipolar disorder, bipolar depression, are different from that in unipolar depression. So while they're very similar, they actually may have different biologies driving them, and therefore some difference in the symptoms, for example, in retardation. Now, depression is the problem for many bipolar patients. In bipolar 1 disorder, for example, this is long-term data looking at symptoms over a 10-year period, self-rated symptoms by patients with regular review, data taken from Judd in America, although similar data has also been found in Europe. And it was found that patients had symptoms more than half the time in bipolar 1 depression. And of those symptoms, depression formed 2/3 of the symptoms, whereas mania or mixed symptoms were only present for about 1/3 of the time. So depression is the main burden that patients experience. In bipolar 2 disorder, they have symptoms as frequently, perhaps if anything more frequently, and depression is a very large part of their burden, and they only very rarely have hypomania or mixed states. So depression is the main problem that patients have, while of course we have to be aware that they're bipolar and treat them accordingly and treat the mania and hypomania when it occurs. The management of depression becomes the kind of key issue as far as patients are concerned and what they want. So when we come to treat the patient, we have a lot of different challenges, and the ones I'm going to focus on are the ones that are highlighted here: getting efficacy, getting benefits in terms of treatment of depression, but also avoiding destabilization, avoiding the patient swinging into a high, are the key issues. Depression also occurs as part of mixed states and also part of rapid cycling. I'm not going to talk about these in any detail, but just mention a little bit about them, and perhaps we could pick up these issues in the discussion period this afternoon. I'm also not going to be able to talk about prevention of suicide. And Peter Haddad, in the final talk of this morning, will talk about the issue, the key issue really, of prevention of recurrence, I think, which is the main issue for bipolar patients, I think. So efficacy and destabilization will be my main focus. So I mentioned I'm going to go through the treatments in order, and then first of all starting with antidepressants. Well, there was some older data suggesting that antidepressants, particularly SSRIs, might work. But the studies were really very small and very limited, and they were all trumped, as we say, by this very large study done by Gary Sachs and his colleagues as part of the STEP-BD program, in which he took 300 patients with bipolar disorder who were all on mood stabilizers, either lithium or valproate, and added antidepressant, either paroxetine or bupropion, to half of them and placebo to the other half, and then studied the outcome in terms of various outcomes: remission, recovery, improvement, and so on. And your eyes are not deceiving you. Placebo outperformed the antidepressant. They were not statistically different between these two. So there was no statistical difference, but you can see, if anything, placebo was better than antidepressants. So in this very large study, there was no signal for antidepressants in bipolar depression. It was a large enough study to be able to look at the subgroups of bipolar disorder separately. So here's the overall result on the left: antidepressants in red, placebo in yellow. In bipolar 1, there was no difference between the two groups. In bipolar 2 disorder, where depression is very frequent and you really want an antidepressant to work, in fact, if anything, they worked even less well in that situation. So antidepressants don't treat bipolar depression, at least as far as this quite large study is concerned. There were some problems with this study which we could discuss, but overall it shows no signal, at least for paroxetine, the SSRI. And this was a well-conducted study, better than the previous older studies. Now, all of the data, including that study, were put in a meta-analysis by McQueen and his colleagues in 2011, and this is the result of that study. So this is all the data for bipolar depression of an antidepressant versus placebo combined together. And so we have 340 patients on antidepressants of various sorts and 565 patients on placebo. So quite a lot of power to detect a difference, and there wasn't a difference. This here shows the summary of these 5 different studies, showing only a very, very small, but not clinically or statistically significant effect of antidepressants. So we conclude in opposition to unipolar depression, where of course antidepressants work, not hugely, but they do work, there is no signal in bipolar depression, at least in randomized controlled trials that have been published. Now, since this meta-analysis was done, well, a further study was done by AstraZeneca called the Embolden 2 study, and it was a study looking at quetiapine in 2 different doses, and I'll talk about the quetiapine result here in these 2 shades of purple in a minute, a little bit later, but for now we just want to focus on the paroxetine study, and this was 118 patients on paroxetine compared with 120 on placebo, and there was no separation here either between the yellow line of paroxetine and the white line of placebo. So further evidence that antidepressants, at least SSRIs and certainly at least paroxetine, doesn't seem to work in bipolar depression in the same way that it would in unipolar depression. So no strong data that the drugs work. What about the issue of whether or not these drugs cause the patient to become manic or hypomanic? Well, in all of these studies put together, they looked at the risk of what they called affective switch, and in fact there was no evidence that the patients were put into mania or hypomania using these antidepressants, were relatively mild antidepressants, SSRIs and the like. Although quite a lot of the patients in this meta-analysis were on mood stabilizers as well. But there was enough patients not on mood stabilizers to see that there really wasn't a switch any greater than placebo. Remember, there's always a switch in bipolar disorder. If you do nothing, some patients will switch into being high from being depressed without doing anything. But the rate for SSRIs is not any higher. We do have some poorly conducted study, open data and results from non-placebo controlled RCTs, which suggests you do find a higher switch rate with stronger antidepressants such as SNRIs or tricyclics, but probably not monoamine oxidase inhibitors than with SSRIs. So the placebo data tells us there's no risk with antidepressants. However, some of the other data from non-placebo controlled, randomized controlled trials suggest that there might be a risk with the stronger drugs in causing switching. And switching is not a good thing. We don't want patients to switch. We want them to get better from their depression, but switching into a high doesn't solve any problems because subsequently their mood is unstable and they may become depressed again. So a summary of the use of antidepressants in bipolar depression is that evidence is negative regarding their efficacy. Now, despite that, we know that in practice, and this is in UK, but also in the USA and Europe, all over the world, a lot of patients continue to be on antidepressants. About a third of bipolar patients in various surveys are on antidepressants. And so why this should be is not clear. It may be that the clinicians are actually right and the antidepressants are helping, but it may be just simply that the patients have got on them and have been stuck on them and it's not been re-evaluated in the light of this new evidence. Some of the patients in various surveys and audits are on long-term tricyclics or SNRIs. Many in high doses are for a long time, and these have been reported to increase switch rates. So there is a question of whether, in fact, many of our patients who are on these long-term doses are actually suffering harm as a result of this, and it's causing destabilization of mood. So the use of these antidepressants, particularly long-term, should be regularly re-evaluated. So I think the summary is that we shouldn't use antidepressants routinely in bipolar depression. There may be a case if in very severe cases of depression or non-response to other treatments, which I'll describe in a moment, when you might require to use antidepressants, but they should be used with caution. Okay, so that's the issue about antidepressants. What about mood stabilizers? So first of all, let's look at lithium. Well, there were some older studies suggesting lithium was superior to placebo in bipolar depression, but all of them were rather poorly conducted studies, conducted many years ago in the 60s and 70s and not very well done. And 3 studies, similar studies, were also negative. So that was the past. One of the interesting studies in the past, though it was quite well conducted, showed some benefits if lithium was optimized above 0.8 millimoles per litre. I did mention earlier that I think there's been a trend for lithium levels to become too low. And this study did show that higher levels of lithium above 0.8 millimoles per litre was effective as a tricyclic, which is probably an effective drug in bipolar depression. and more so than placebo. So that's something to bear in mind, that if a patient is on lithium, then optimizing the lithium may be a strategy if they become depressed. But what about newer studies? Well, part of a large study called Embolden 1 was done by AstraZeneca, which mainly looked at quetiapine, but one wing of that study was to look at lithium versus placebo. And in this case, there was quite a number of patients studied, 267 patients, half of them on placebo and half on lithium, and they were studied after 8 weeks. And there was no separation of lithium from placebo on any outcome. This shows the outcome on the MADRS scale, the depression scale, but on no outcome was there any benefit of adding lithium in bipolar depression. So this larger, well-conducted study, I think, suggests that lithium is not an acute treatment of bipolar depression. Now, what about lamotrigine? Well, it's a rather complicated story, and not a very nice story in some ways. This was the first study of lamotrigine in bipolar depression carried out by a group of workers in the United States in the late 90s. And it was a very exciting result. It suggested that there was an effect of lamotrigine in doses of 50 milligrams in yellow or 200 milligrams in purple in acute bipolar depression. And these are the results on one of the scales using 2 different statistical methods, suggesting statistical improvement, particularly on the observed cases, the cases who went to fruition. So that was very exciting, but there were some problems with this result. One of them was that the result was only found on one of the scales, on the MADRS scale, shown here, but there was no, so there was a statistical benefit on that scale, but there wasn't a statistical benefit on the Hamilton scale. It was non-significant. So that always suggests there's some problem with the result, and it wasn't clear-cut. There were some question marks about that particular study. What then happened, there were then 4 other studies of lamotrigine in acute bipolar depression done by the company, but none of them were published. But John Geddes from Oxford was able to get these studies, these unpublished studies, by a Freedom of Information Act in Europe, and was then able to analyse them, these 4 unpublished studies and the 1 published study, and he put them together in a meta-analysis published in the British Journal of Psychiatry in 2009. And what this showed was that, in fact, there was actually a very small effect of lamotrigine in terms of bipolar depression, but it was really quite small and only found on some outcomes. So these are the effect sizes here, compared with no effect being the middle line here, and these are really quite small effect sizes, 0.27, 0.22, and so on, and one of them was actually non-significant. So the message is that lamotrigine is a very, very weak antidepressant for bipolar depression, and therefore not really to be recommended for acute and particularly for severe bipolar depression using this set of data. There was, however, an interesting study done independently of drug companies where people, a group in the Netherlands and in Scandinavia, studied the effect of adding lamotrigine or placebo to lithium. They had patients on lithium who became depressed, and they then added lamotrigine or placebo. And the interesting thing was that there was a difference here in adding lamotrigine on top of lithium compared with placebo on a number of outcomes, particularly the MADRS, the primary outcome. So I think the story is that lithium on its own is not, lamotrigine on its own is only very weakly antidepressant, but when added to lithium, there's a reasonable degree of antidepressant effectiveness, particularly if that lithium is given in an adequate dose, which it was in this particular study. Now, what about valproate? Well, valproate's a bit of a messy story. There have been 4 studies of valproate in bipolar depression, which are shown here, and all of these studies, these 4 green dots with the confidence intervals here, were actually non-significant. Each of the studies was non-significant, so there was no effect of valproate as a treatment for bipolar depression. However, if you added them all up together, there was a significant benefit. And this is where you have to decide between whether the 4 small studies are telling us the answer or whether the combined study is telling us the answer. I think the answer is probably the effect is pretty weak, and is not really very clinically useful. So a summary of the use of mood stabilizers in bipolar depression is there's limited data, but there's some evidence, limited evidence for efficacy for the medications as a group. All of them have small amounts of evidence for a small effect. So the weak effects of lamotrigine, when you remember we have to increase it very slowly, and particularly in the young or those on valproate, means that it's not the treatment of choice for acute bipolar depression, particularly where rapid effects or major effects are required. There is some data that increasing the blood level of lithium to 0.8 millimoles per litre or combining it with lamotrigine might produce some benefits. So none of this data is strong, but these nonetheless can be quite useful things clinically to do in particular circumstances when patients come to the clinic. So I'm now going to move on to look at antipsychotics. And the first part of that is to look at typical antipsychotics. And there's only really been one study done of typical antipsychotics in bipolar depression, and that was a study of perfenazine, the typical antipsychotic perfenazine, which is of course the one that was effective in the Katie trial in schizophrenia. And here when perfenazine was added to a mood stabilizer compared with placebo added to a mood stabilizer, the outcomes were very poor. In fact, more patients on the perfenazine got depression and poor outcome, relapse of mood episodes compared with placebo. So perfenazine, a typical antipsychotic, didn't seem to have benefits, and in fact may have caused quite a lot of side effects, including movement disorder, which, as Hamish mentioned in his earlier talk, bipolar patients are very prone to. But the situation for so-called atypicals is actually much stronger. And this was the first study done by Maurizio Tone and his colleagues at Lilly, and he took a large, very large group of bipolar depressed patients and studied them either on placebo in black, olanzapine in yellow, or the combination of olanzapine and fluoxetine, which is here in purple. So at one point, Lilly were going to market this combination, olanzapine-fluoxetine combination, which we were going to market as Zip-Zac, was what it was going to be called. So Zyprexa and Prozac together were going to be called Zip-Zac, which was probably likely to be a very effective drug, quite an exciting name. And in fact, they showed with the Zip-Zac or OFC, there was actually a very good effect on bipolar depression compared with placebo. Olanzapine itself had also an effect compared with placebo, but not quite as strong. Now, subsequently, they haven't marketed OFC as a combination drug because of problems with weight gain with olanzapine, but nonetheless, one can make that combination up with a dose of fluoxetine of about 20 milligrams and a dose of olanzapine between 5 and 10 milligrams. So this is an effective treatment. What about olanzapine and so on? Well, it's possibly an effective treatment. We need to know more about that. And in fact, that's now been studied in a study by Maurizio Tone, looking at olanzapine versus placebo alone in a larger study. And here there were benefits for olanzapine compared with placebo in terms of improvement in depression over a 6-week trial. But again, you can see the effects are not enormous. The effect size is really quite small, around 0.22. So olanzapine on its own is an effective antidepressant in bipolar disorder, but it's a relatively weak one. And in this study, of course, they did find quite a lot of changes with weight, fasting cholesterol, and triglycerides. So olanzapine does work. Another study that's been done subsequent to the original study of olanzapine-fluoxetine combination was to compare it with lamotrigine. And here, in quite a reasonable-sized randomized controlled trial, olanzapine-fluoxetine combination outperformed lamotrigine, which, as I mentioned earlier, has effects, but relatively weak effects. But again, olanzapine-fluoxetine combination was associated with quite a lot of adverse effects and greater weight gain. So at least we have one effective treatment, olanzapine-fluoxetine combination, but the complication, of course, is the frequency and the difficulty of side effects. And particularly when you add it to mood stabilizers, valproate or lithium, which already might be causing weight gain, then we have quite a significant problem for that combination. What about other antipsychotics? It was assumed, like in mania, all antipsychotics would be the same, but it seems that's not the case. And some of that evidence is that, for example, aripiprazole actually proved to be non-effective in the treatment of bipolar depression. So this study, this slide shows two studies, both identical, of aripiprazole versus placebo in quite good numbers, showing no benefits for aripiprazole, which was very disappointing because aripiprazole, of course, doesn't cause much weight gain. It might have been a good drug for bipolar depression. Sadly, there's no efficacy shown in these particular studies. Which leads us to the quetiapine studies. And quetiapine, under AZ, have done a whole lot of studies in bipolar depression. Should be congratulated for tackling this difficult area, which is a very common clinical problem. However, we have to be also aware there's no independent replication of the studies I'm about to show you. They've not been done by anyone other than AstraZeneca. Now, in all these studies, they have a particular dosing regime for quetiapine, which I just want to mention. So that quetiapine 300 milligrams is increased from 0 to 300 milligrams within 4 days, and quetiapine 600 from 0 to 600 within about 8 days. Quite rapid titration. But I think that is useful because if you do it very slowly, a lot of patients will complain of sedation and not increase the dose. You need to have probably this rapid titration to get people to these doses which are required for treatment. And first of all, they did two studies called Boulder 1 and Boulder 2, which were identical studies looking at the effects of 300 and 600 milligrams of quetiapine in purple compared with placebo. And both studies showed really quite significant effects, clinical effects, for the quetiapine compared with placebo, with 600 milligrams being slightly more potent than 300 milligrams. I know it doesn't show it on the slide, but it was slightly more potent in terms of bipolar depression, but both doses were very effective. Now that raises the question, is quetiapine affecting bipolar depression by treating the core symptoms of depression, or is it simply being useful as helping with anxiety or helping with sleep and these kind of more non-specific effects? Well, the studies to date have shown that while, yes, it does decrease an anxiety and improve sleep, these studies in purple are the quetiapine effects, white as placebo. It also affects the core symptoms of depression, so it seems to be a genuine antidepressant effect. Now, there's enough data from these two studies, the Boulder 1 and the Boulder 2 studies put together, to show some data for quetiapine in both bipolar 1 disorder and for the first time in bipolar 2 disorder, effectiveness of quetiapine in these two doses. As would you expect from a drug that has inbuilt anti-manic properties, there was no treatment-emergent mania in any of these studies. So the actual rate for mania developing was actually less than placebo with both doses of quetiapine. But of course, a lot of problems from these drugs are related to side effects. And in one of the studies, I've shown the data here, showing the amount of problems that patients get with somnolence, sedation and dizziness compared with placebo or compared with paroxetine. So remember, these patients are already depressed, they've already probably got retardation, and on top of that you add an antidepressant that causes the patient to feel sleepy and tired. It is a bit of a problem, and many patients can't tolerate these doses, although those that can tend to get a good clinical benefit. Adding all the studies on bipolar depression that AZ have done together shows benefits both in bipolar 1 and bipolar 2, as I showed earlier, but also in depression occurring in rapid cyclers and in non-rapid cyclers, the purple doses versus green being positive here as well. So there is data in these larger groups too. Why should quetiapine be effective compared with other antidepressants? Well, we don't really know, but one of the effects might be its effects, the effect of its metabolite norquetiapine, which is a potent inhibitor of noradrenaline transporter and a partial agonist at 5-HT1A receptors, both of which are thought to carry antidepressant properties. So it's probably the fact that the drug has this metabolite, which has these effects, that allows it to show this particular signal. Now, more recently, lorazepam has come on the market. This is another antipsychotic useful in schizophrenia, but it also has really quite strong data, like quetiapine, in bipolar depression. And this is its data as monotherapy here on the left, compared with placebo, and also with a mood stabilizer as part of co-therapy, compared with placebo and mood stabilizer, lorazepam and mood stabilizer. So good clinical benefits. An interesting thing about lorazepam, which is now available in the USA, but not yet in Europe for treatment of bipolar disorder, is that it has very much improved side effect profile It has little effect on weight, or on triglycerides, or on glucose. So hopefully this drug will become available more quite soon for us, and it offers the opportunity of minimizing side effects and increasing tolerability. I'll just skip over that slide. So a summary of the antipsychotics in bipolar depression is that there is no data on typicals, and in fact they might worsen the condition. There's evidence for quetiapine in a lot of studies. There's evidence for olanzapine with fluoxetine and for lorazepam. These are the key ones. There's a lack of evidence for a number of antipsychotics. I showed the data for aripiprazole, but for other ones as well. So it's a specific effect related to the drugs that I mentioned earlier, and probably that's related to their neurochemical effects. Now, NICE, taking all the data now, so I've looked at antidepressants and mood stabilizers and antipsychotics. NICE were able to look at all this data put together in this analysis. This is a complicated analysis where each of these drugs has been compared with placebo very frequently, and using this kind of analysis you can then get some degree of the relative efficacy of these drugs compared with each other if you do have enough data to put into this system. And doing that, they found that 6 interventions were statistically significant compared with placebo, lorazepam, valproate, quetiapine, a combination of fluoxetine, olanzapine alone, and lamotrigine. But many other interventions mentioned here were negative. And they put that data together in this particular slide thing here, which you can get from the NICE website. And this shows the effectiveness here of these different treatments. Those in red are statistically and probably clinically significant. And this shows the effect on discontinuation, which is a marker of tolerability. So the ones, the strongest drugs were olanzapine, fluoxetine, but that also showed the biggest discontinuation effectiveness. So really we want probably to be in effect drugs down in here, which have reasonable effectiveness, but don't have major problems with discontinuation. So, now just briefly on non-pharmacological treatments, ECT does work well. There's reports of effectiveness in mania, as Hamish mentioned, but also in depression and refractory mixed states. Bilateral is generally more effective. Continuation treatment might prolong recovery, but there's no real evidence for maintenance. And interestingly, switch rates are relatively low. So ECT definitely is a treatment for bipolar depression. And the indications are, as you would find in unipolar disorder. Transcranial magnetic stimulation, which we hoped would be of benefit because of its less side effect profile, doesn't seem to be beneficial in bipolar depression, at least the studies I've looked at so far. So putting all this together to summarize, so it's a very frequent disorder, it's often severe, the evidence base is still quite weak. Most focus should be on the prevention of depression and the prevention of mania, which will be the topic of the next talk. And there, particularly in terms of preventing depression, lamotrigine and quetiapine have the best evidence. If taking, so what about, to put everything together, this is adapted from NICE. If a person develops moderate or severe bipolar depression, you should offer fluoxetine combined with olanzapine in these doses here, or quetiapine. That should be the standard treatment, either OFC or quetiapine. If there's no response, or the patient prefers, you could try olanzapine or lamotrigine. These are the two alternatives. Remember, for lithium, you should check the blood level and optimize the level. And if there's no response, you could then add to the lithium, you could add one of these drugs here, because there's data on these combinations. But in all these situations, tolerability is the key issue. So that's the current state of evidence and recommendations for the treatment of bipolar depression. Antidepressants, of course, might be used. They'd be used in patients who didn't respond to those things, should never be given alone. And if they're given, they should only be given probably for a relatively short period of time. There's no evidence that they help protect against the recurrence of depression. So you should discontinue them if patients make a response. So only to be used if the patients fail to respond to other treatments, and only with mood stabilizers, and then stopped. So I've emphasized the things we have evidence about, but I must just reflect that we have areas where we're really unclear. For example, we don't know about the use of antidepressants and how long they should be used. Sedating antipsychotics, where we have the best evidence, like olanzapine and quetiapine, is that a wise thing to do in patients with severe depression who have a lot of retardation? We'd like to find drugs that didn't sedate, but so far none are clinically available, or at least regularly available. And the other problem is that many patients develop subsyndromal depression. They develop low-grade depressive symptoms that are having a major impact on their life, but we have no evidence of how to treat if it doesn't reach the criteria of being an episode. And so there, we have no pharmacological evidence, so I think we need to rely on the use of prophylactic medication and psychosocial treatments, for example, psychoeducation. So thank you very much for your attention. I'm very pleased to answer any questions.
Okay, well, good morning, everyone. It's a great pleasure to be in Turkey, to be part of this day's study on bipolar disorder. So I'll start by showing a competing interest slide. When we treat bipolar disorder, we have a number of goals as clinicians. We want to totally control any residual symptoms that have been left from acute stage of treatment. We clearly want to prevent new episodes of illness arising, and these may be full syndromal episodes or they may be sub-syndromal episodes. And ultimately we're trying to reduce mortality and reduce morbidity, and in doing so prevent patients suffering and improve quality of life and functioning. As clinicians, I think there's a number of key questions that face us, and we're going to look at these in this talk. One is, when should we consider initiating long-term treatment? A second key question is, when we start long-term treatment, how long should it continue for? And thirdly, what medications is it appropriate to use in long-term treatment? So let's start with the first of these questions. When should long-term treatment be considered? I think there's two key trials we can look at to help answer this. This first study was published by Maurizio Towin. It's the largest study of the long-term outcome of people who've been hospitalised with their first manic episode. And you can see that 166 patients were followed up for at least 2 years. This was an observational study. There was a high recruitment and a high retention rate. And if you look 2 years down the line, the outcome differed depending on where you set the bar. If you said how many patients no longer suffer from a syndrome of mania or depression, you're doing very well. 98% of people have recovered. If your definition of recovery was everyone who's got no significant symptoms, it's 72%. So, about a quarter of patients are left with low-grade symptoms. If your level of recovery was, is the person functioning as well as they were before they became ill, we're not doing very well. The majority of people are not functioning at their pre-morbid level. So whether you regard the outcome as good or bad depends on where you set the bar. This is what's happening 2 years after that first episode. In this next slide, we're going to look at what's happened to people over the course of the 2 years. And you can see that 40% experienced a new episode of illness. So just to recap, at the start, everyone's got mania. And if you follow them over 2 years, 40% get well, but half of them have a second episode of mania, or half of that 40% go on and get an episode of depression. And on average, they were well for 6 months between the first 2 episodes. Another 19% didn't get well from the first manic episode. They immediately switched into a mixed or a depressive state. There's a slight overlap between these two groups, but what it means is the majority of patients, 57%, had a new episode of illness within 2 years of follow-up. Nicol's already shown you this slide. I'll just go over it because it is a very important slide. Just let me see if I can get the laser pointer working. Okay, top. Okay, thank you. Okay, this is an important study. So this is a group of bipolar 1 patients followed up for 10 years, as Nicol said. They rate their mood every week, and half the weeks over 10 years they've got symptoms. And then if you look at these mood diaries and say, what are they complaining of? The vast majority of the time it's depressive symptoms. Similarly, look at the bipolar, 2 patients over 10 years, half the weeks over 10 years, they have symptoms. And if you say what sort of symptoms, it's largely depressive symptoms. So bipolar disorder is a primarily depressive disorder. On this slide, I've broke the weeks down that they had symptoms, depending on whether they were syndromal or subsyndromal. And you can see that most of the symptoms they're complaining of are subsyndromal. So bipolar disorder, you could argue, is a primarily subsyndromal depressive disorder. And that's very different to how we often conceptualise it, where we often think of it and concentrate on the manic episodes. Guidelines over the years have tended to move to recommending that long-term treatment started earlier rather than later. Let's just concentrate on the latest 2014 NICE guidance. This says, after each episode of mania, this could be your first episode of mania or your first episode of bipolar depression, discuss with the patient the use of long-term treatment. So even after the first manic episode, you should be highlighting prophylaxis. And then it's very much up to you and the patient to decide whether you feel the benefits outweigh the risks. I think in most cases, the benefits would outweigh the risks. If you've started long-term treatment, how long do you continue it for? Jules Angst followed up patients with many psychiatric disorders in an observational setting for over 40 years. The patients were assessed regularly. And in this analysis, he looked at the long-term outcome for bipolar and unipolar depressive patients. And the relapse rate in bipolar disorder was twice that you saw in unipolar depression. This is an important finding. One of the hallmarks of bipolar disorder is its high rate of recurrence. That's one of the key features about it. Unfortunately, patients tend to get ill a lot. In his study, patients had an episode of illness on average every 2 years, and men and women didn't differ. There was no evidence over the 40 years that the illness burnt out. The rate of relapse remained constant. Now, the implication there is that if you decided to embark on long-term treatment today, as long as your decision was right, the patient's still going to need long-term treatment in 5 years or 10 years because the illness doesn't burn out. So rather than saying how long should you continue treatment for, I think it's better to turn the question on its head and say, can you see a good reason to stop treatment? Rather than saying, is there a good reason to continue it? And there may be reasons during follow-up why you do decide to stop treatment. It may be that as the person gets older, he tolerates the medication less well. The person may develop medical comorbidities, yet your drugs interact with. It may be when you started treatment, the person was a university student and had their finals coming up and you couldn't risk them getting ill. It may be in the future they're in a job that isn't very stressful, they've got long-term security. So it may be that the risks of the illness do reduce somewhat, and it could be that over time the risks of the medication get higher. But very much I think it's looking at justifying stopping treatment rather than justifying continuing. So the rest of my talk is going to focus on what medications are we going to use long term. Now, there are only 5 medications that have been shown to be better than placebo in studies that have gone on for at least 1 year. So randomised controlled trials, minimum of 1 year duration. So these are the 5 medications we're going to mainly consider in long-term treatment. There's lithium, very important medication, tends probably to be underused, but very important. We then have 3 second-generation antipsychotics, olanzapine, aripiprazole and quetiapine, and then we have lamotrigine. To this group of 5 medications, I would also add sodium valproate. It doesn't have a long-term placebo-controlled study, but there is reasonable data to make you think it's reasonable to use. And NICE does support it as a long-term agent, but not in women. We'll say a little bit more about that later on. Okay, so NICE was quite dogmatic. They said that lithium was a first-line maintenance agent. I think that's somewhat simplistic. I think the data for quetiapine is probably equally good. They said if lithium wasn't effective, you could add valproate. I think that's reasonable to do, but strictly there is no evidence that lithium and valproate is better than lithium alone. So it's rather odd that NICE, which prides itself as being an evidence-based guideline, would recommend that. NICE said that if lithium wasn't tolerated or didn't work, you could use valproate, olanzapine and quetiapine. I think that's reasonable, but again it surprises me that they didn't mention using aripiprazole or lamotrigine. Let's look at the key drugs I've mentioned in a little more detail. So lithium, we know it's an acute anti-manic agent. John Geddes some years ago, 10 years ago now, published a meta-analysis and he looked at 5 key studies and he showed that lithium compared to placebo reduced relapse. But the benefit was largely in terms of reducing the relapse of mania. So traditionally, lithium's been seen as a long-term drug that prevented the relapse of mania. But in 2011, a very important study was published by Weisler, which showed that lithium was effective in preventing the relapse of depression. And we look at that study in a bit more detail later on. We also know that long-term lithium appears anti-suicidal, and this may reflect an anti-impulsivity effect. So lithium's a good long-term drug, but its side effects can be problematic, and I think Hamish has already talked to you about some of the side effects of lithium, including the fact you can get a withdrawal syndrome and the issue of a narrow therapeutic index as well. There's only been one placebo-controlled study of valproate long-term. This was a study done by Bowden. The slide isn't... No, it is showing up okay. So they took patients with bipolar disorder who were well. They were on lots of different drugs. And they randomised a third to go onto placebo in black. And you can see that over the year, over half of the patients on placebo relapsed. A third of the patients went on valproate, and a third went on lithium. And really, the valproate and lithium curves are very similar to the placebo curve. So neither drug worked, and you really call this a failed study. The reason why it failed was the patients at the beginning are on all sorts of different medications. And the study really doesn't have the power to pick out whether valproate or lithium works. If you wanted to show that lithium or valproate worked, you should really have recruited a group of people who responded to lithium and then randomised them to stay on the drug that got them well or go to placebo. And when you do a sub-analysis here and you look at people who started off on valproate and then had it taken away to be put on placebo, or who stayed on valproate that got them well, valproate does separate. So in secondary analyses, valproate did look okay. In support of the long-term effect of valproate, we have this study done by Lilly, where people who are manic are put on olanzapine or valproate. The YMAR scores drop rapidly, showing that both drugs are anti-manic. They're not re-randomised, but they're just followed up double-blind for a year. And both drugs, long-term, manic symptoms remain low. So there's no evidence that the drugs were acutely effective in mania, and then they relapsed into mania. And seeing that we know that olanzapine from placebo-controlled studies is a reasonable maintenance agent, I think it's reasonable to look at this study and say that valproate has long-term anti-manic effects. We can probably talk more about this in the afternoon, but over the years, 10 years ago people said, if you use valproate in women, use it with caution, talk to them, make sure they're on contraception. This is because valproate can cause teratogenicity and it can lower the IQ of the newborn child. Over the years, the guidance has got much stronger. And in the UK, it really now is, you cannot prescribe valproate to any woman who could get pregnant, even if she's on reliable contraception. And I think the concern is, you saw them today, they had a coil fitted, you gave them valproate, it was fine, but they're stable, you're not going to see them for 6 months. And how do you know in the interim they don't get some pain, the coil's removed by someone who doesn't know as much as we do about valproate? So there's very strict guidance now in the UK. Carbamazepine, my advice would be don't use this drug unless you're really stuck. It does have some anti-manic effects, acutely and long-term, but it's a very problematic drug. As you all know, it induces hepatic enzymes, and so it lowers the plasma levels of virtually any drug you prescribe it with. And that interaction's very unpredictable. In some people, effect will be as marked as to halve the plasma level of antipsychotics. It is teratogenic, not to the extent of valproate, but it's associated with neural tube defect. And in my experience, it's a very toxic drug. I've seen more people with nausea, vomiting, unsteadiness on carbamazepine than they ever did with lithium. And because of those side effects, if you do use it, you have to build up the dose very slowly. I've had quite a few patients who wore glasses, and when I took them off carbamazepine, they were able to throw their glasses away, their eyesight improved, which is very interesting. Lamotrigine is a useful long-term drug. So on these next 2 slides, we have 2 placebo-controlled trials of lamotrigine have been combined in a meta-analysis. And here we're looking at people to begin with who are all well. They're randomised to remain on lamotrigine, which they responded to, or to switch to placebo. And we're looking at relapse into depression over 18 months. There are no miracles. People on lamotrigine do relapse into depression, but more people relapse into depression if they're on placebo. And the difference there is the benefit of the drug. So lamotrigine does offer some protection against relapse into depression. It also offers some protection against relapse into mania. So here's people who are well to begin with. This is relapse into mania over 18 months. People on lamotrigine did become manic, but more became manic on placebo. So, the reality is most drugs we use probably have some prophylactic effect on both poles, but it's often more marked on one pole than the other. So to recap so far, lithium, our modern thinking is it's probably equally effective in preventing relapse into depression and mania. Lamotrigine predominantly protects against depression. Let's now look at the second generation antipsychotics. As I said, 3 of these, olanzapine, aripiprazole and quetiapine, have got data for the long-term effect. The drug with the best data is quetiapine. So I'll go through these studies fairly quickly, as you're probably familiar with many of them. So this is the first long-term study for olanzapine in bipolar disorder. So you look around your clinics for people with mania. When you find them, you put them all on olanzapine, open label. And some people don't respond, and we're not interested in those. But the people who do respond to olanzapine, we then randomise them at this point, so they can stay on olanzapine double blind, or they switch to placebo. and are followed up for 12 months. And this is what we see. If we look at all relapses, 80% of people in this study on placebo relapse within 12 months. This emphasises a key message that everyone's been saying to you today. Bipolar disorder is a highly recurrent disorder. On olanzapine, there are no miracles in psychiatry. In olanzapine, people still relapse, but you've roughly halved the relapse rate. It's gone from 80 to 46%. If you say, well, what's olanzapine done? Has it been beneficial by preventing depression, preventing mania? You can see that there's no difference between relapse into depression on olanzapine and placebo. No significance there. But if you look at relapse into mania, that's where the beneficial effect has largely come. So olanzapine is predominantly protective in preventing relapse into mania. So the opposite of lamotrigine. All well and good show that olanzapine is better than placebo. How would it compare to lithium? So in this study, we look around for people who are manic. We treat them with a combination of olanzapine and lithium. We take the people who got well, and we randomise them so we take one drug away. So we either remove the lithium so they stay on olanzapine alone, or you remove the olanzapine so they stay on lithium alone. So they've responded to combination. You take them, you randomise them to the olanzapine or the lithium, and you follow them up for a year. Big study, over 400 patients. Average dose of olanzapine, about 12 milligrams. Average dose of lithium, about 1 gram. Fairly decent plasma levels, average plasma levels over the course of the study. And this is what you find. The overall relapse in both groups is about 1/3 of people relapsing, and it doesn't quite reach significance. So the bottom line is olanzapine and lithium equally effective. Numerically, olanzapine does look a little bit better. Relapse into depression, no difference. Relapse into mania, olanzapine did do a bit better here. If you wanted a pragmatic outcome, the number of patients admitted to hospital with a relapse was lower on olanzapine. So you'd probably argue that in this study, olanzapine did have the edge. On the other hand, you may argue that olanzapine causes a lot more weight gain and it causes a rise in glucose and lipids. But both drugs looking reasonably good. Aripiprazole, long-term study of people who responded to aripiprazole, followed up for 6 months. Relapse rate into mania, much higher on placebo than aripiprazole. So staying on aripiprazole here in the yellow protects against a relapse to mania. Nicol showed you that aripiprazole did not work as an acute bipolar antidepressant, and no evidence that it protects against relapse into depression. You can skip that slide. This is one of the most interesting studies I'll show you. So this is this key study by Weisler. So this study is worth spending a little bit of time on. Okay, first thing you can notice is, it's a huge study, over 2,000 patients entering are screened there. And they look for patients who've got depression, mania, or a mixed episode. And that's because quetiapine is licensed to treat all those problems. In the olanzapine study I showed you, we just recruited manic patients because that's where olanzapine's acutely effective. But here we can take people with depression or mania. They all get treated open label with quetiapine. We take out the people who respond, and 1/3 of them stay on quetiapine. And the average dose is about 550 milligrams. It's also an interesting study because, look, it's got a 2-year follow-up, so longer than many of the studies. 1/3 of the patients switch to lithium. And this is a bit of a gamble I mean, these are people who've been treated with quetiapine. We have no idea whether they'll tolerate lithium or whether they'll respond to it. So this is quite a tough call for lithium to do well. You've taken them off a drug they did well on and put them on a drug you've got no idea how it'll do. And then a third of the people get put on placebo. And these are the results. Compared to placebo, both quetiapine and lithium increased the time. She stayed well longer before you got any relapse, before you got a depressive relapse, and before you got a manic relapse. So this analysis is telling you that quetiapine protects against relapse into depression and mania, and it's also telling us that lithium does the same. In the analysis, quetiapine looked more effective, but it's not a fair analysis because you've enriched the sample to be quetiapine responders. And to be fair, it's a very strong finding that lithium did well in this study because you didn't design a study to look at people who'd acutely responded to lithium. There's very few studies I know of in psychiatry where you'd show a prophylactic effect when you hadn't enriched the sample for people who acutely responded. This is a very strong finding for lithium. And it's quite an interesting finding also that a drug company, AstraZeneca, whose job is to market quetiapine and sell it, they have actually conducted the best ever study for lithium. Largest maintenance study ever done for lithium. I think it's probably fair to say there's more patients in this lithium maintenance study probably than all the maintenance studies done in the previous 50 years. I'd have to check the figures, but I'm fairly sure that would be the case. Last few minutes, what about using long-term treatments in combination? The most common design here is, as Hamish told you, there's a number of acute studies where you've got people whose mania has responded to lithium plus an antipsychotic or valproate and an antipsychotic. And quite a lot of the companies have taken these people who acutely responded and they've randomised them to stay on the combination or to have the antipsychotic stripped away and replaced by placebo. And all those studies show that if a combination got you acutely well, you're more likely to stay well on the combination than to have the medication simplified. And that was shown in one long-term study of olanzapine, lasting 18 months, a one-year study of aripiprazole, and two two-year studies of quetiapine. So again, this is why I say I think the quetiapine data is quite good. Here in combination, we have two studies. These other drugs just have one. Both of those studies are actually quite poorly designed. And this quetiapine has two. The studies are 2 years in duration. So bearing in mind, I think the quetiapine studies are better. I will show you those. The design, again, was to take people who had any acute bipolar illness, to treat them acutely with quetiapine plus lithium or quetiapine plus valproate, take the people who got well on the combination, randomise them to stay on what got them well, or remove the quetiapine and leave them on lithium or valproate. So this study is following the patients up for 2 years. Again, there are no miracles. People on the combination, about 40% of them have relapsed over 2 years. But if you take the quetiapine away, it's 75% you've relapsed over the 2 years. So the combination did far better than going back to lithium or valproate alone. That was any relapse. Here we have on the next slide. I think what's happened here. There we go. This is relapse into depression. And you can see that staying on the combination halved your risk of relapsing into depression. And I think I've missed a slide out. The combination was also effective in reducing relapse into mania. This balance study is important because it's one of the few non-industry sponsored studies. This study compared lithium on its own to valproate on its own, or lithium and valproate. And it clearly showed that lithium on its own was better than valproate on its own. So lithium as a long-term agent is better than valproate. It showed that lithium and valproate were better than valproate on its own, but it didn't have the power to say whether lithium and valproate was superior to lithium alone. Long-term use of antidepressants. I'm showing you data from a meta-analysis here. Just concentrate on these 2 bullet points. In this sub-analysis, you looked at people who were on a mood stabiliser plus an antidepressant, or people who were on a mood stabiliser on its own. There was no difference in depression between the 2 arms, so a long-term antidepressant conferred no benefit. On the other hand, there was no evidence of more mania here. So to be fair, the suggestion was, if you want a mood-stabilising drug, the likelihood of the antidepressant causing instability or causing mania, that wasn't seen in this analysis. In this second analysis, it's an antidepressant alone, without a mood stabiliser to maybe get rid of any harm, or it's a mood stabiliser on its own. And in this analysis, there is no difference in the risk of depression, so the antidepressant confers no advantage, but there is more mania when the antidepressant is used unprotected or naked, as it were. So there's no evidence long-term that antidepressants are of any benefit. Saying that, in the real world, I think we all do have patients on long-term antidepressants. We all have patients where our clinical judgment is, when we've juggled those drugs around, we feel there is a benefit. But you certainly shouldn't routinely be using antidepressants long-term. You should be convinced in your own mind that in that individual patient there is a benefit. I've gone through a lot of ground. Let me quickly summarise what we've looked at. Offer treatment early in bipolar disorder because it's a recurrent disorder. The choice of the medication needs to be made on an individual patient basis, and you probably need a discussion with the patient about the different efficacies of drugs and the different side effect profiles. Placebo-controlled data suggests there are 5 key drugs for long-term treatment: lithium, lamotrigine, olanzapine, aripiprazole and quetiapine. Olanzapine and aripiprazole mainly work by preventing mania coming back. Lamotrigine mainly works by preventing depression coming back. And then we have 2 drugs, lithium and quetiapine, that appear equally effective in preventing mania and depression coming back. I think one of the differences between those 2 drugs is there is evidence that quetiapine works as an acute antidepressant agent, whereas, as Nicol said, the evidence that lithium is an acute antidepressant isn't particularly good. Clearly, those 2 drugs differ quite a lot in their side effect profiles. We also have indirect evidence for valproate. So although it's not licensed for long-term treatment, all guidelines across the world would suggest it does have a place. We know from the balance study that it's not as good as lithium. And I have again got to emphasise this issue about do not prescribe it to women where there's any potential of them getting pregnant. I should also point out to you that nearly all the studies we looked at are based on studies where the drug worked acutely. So when I've told you that olanzapine and aripiprazole prevent relapse of mania, strictly I should be saying where somebody has responded, where someone's mania has responded to aripiprazole or the mania responded to olanzapine, staying on that drug will prevent a relapse. I've also highlighted there is no proven benefit from antidepressants as long-term agents. The evidence to support combinations is limited. Clearly, when you use combinations, you have more drug side effects than when you use a single agent. The main conditions or areas when you use a combination is where somebody required a combination to get them well. They're more likely to stay well if you just leave them on what got them well. Also, if you have someone who's on one maintenance agent and they start to relapse, we often add a second maintenance agent in at that point. The evidence for using combinations is strongest for combining lithium with an antipsychotic and valproate with an antipsychotic. It's very important that we monitor for side effects during long-term treatment, and sometimes the management of bipolar disorder is very problematic and challenging, and so it's important to have access to clinicians in your units with special expertise, or ideally to tertiary affective disorder clinics. I'm going to stop there, and I'd like to thank you for your attention.